A very good afternoon to everybody in India and a good day to people across the world who have joined us today. COVID-19 has changed the world. Some of us have been deeply impacted by the virus, losing loved ones, and are learning to live with the grief. Others amongst us are learning about our bodies and how they react in ways that we hadn't been cognizant of before. Each of us is coping with the psychological trauma of loss and grief. This year has also seen some of the most stunning scientific achievements of this last decade. It is against this background that we decided to hold this conference on COVID and the Connectome. It looks at some very specific questions around the implications of COVID on the brain. The hope is that this conversation can spur scientific research into some of the lesser explored and more long-term questions. In this endeavor, we are very excited to be partnering with the Dassault Systems 3D Experience Lab. The lab is a new way to foster entrepreneurship that merges collective intelligence with a cross-collaborative approach. Some of the most exciting innovations that I know of across fields are being fostered in the lab. And I would like to introduce our mentor and friend, Suhas Pritipal, to introduce the lab and its work. Suhas currently leads the Dassault Systems 3D Experience Lab Global Accelerator Program from India. He has been working closely with the Indian startup ecosystem and is right at the center of the cross currents between innovation centers, startup incubators, and academia collaboration programs. A very warm welcome, Suhas.
Thank you, Naina. At the Experience Lab, we are supporting startups, innovators, makers, entrepreneurs by mentorship and by 3D Experience platform. We at the Experience Lab are supporting 40 startups globally, out of which 4 are startups are from India. BrainSight is one of the innovative startups out of them, combining artificial intelligence and neuroscience to enable a great precision in neurological and psychiatric investigation for accelerating patient outcome, which is bringing the future. The brain is final frontier, as a lot of people would say. How you build a tool to understand this complex organ, which has 86 billion neurons speaking to each other. That's almost data of entire city, just for one person. Now thinking on a mining data across a lot of cities to understand the pattern specific to dementia, schizophrenia, etc. It requires some very cutting-edge technology coming together. For example, one need to be able to analyze the complex data, mine for patterns across it, simulate various scenarios, while doing all this keeping the complexity of clinical studies in mind. That's we are working with BrainSight team. We provide our cutting-edge tool, Medidata, out to combine image and data clinical study platform to allow all clinical to conduct a brain study with minimum work. The idea being, as a clinician, you have a focus of administrative work of clinical studies as such, exploring questions that interest your benefit of your patient. We also help with the softwares like BioVia and CATIA to simulate various conditions. We believe features with clinicals will be able to personalize the brain twin of patient. Based on our and BrainSight technology, we will be able to take the informing decisions on how the best we can help to for the patient. The Experience Lab is not only supporting disruptive innovations or transforming startups, but also building a community for collaboration. We support frugal innovation to nurture grassroots innovation, and we have created neuroscience community to bring all the researchers around the world to understand brain. The Experience Lab is a hub of community to groom innovation, startups supported by UN Sustainable Goals, and create dimension to make a world a better place. Thank you.
Thank you, Suhas, for the introduction to the exciting things, especially in the healthcare field that the lab is supporting. India is at the cusp of a healthcare revolution, and your work in supporting startups will help it go to the next level. I would now like to introduce our moderator of the day, Dr. Naina Picardo. She's a professor in the ENT department at CMC Vellore. She went to the prestigious Armed Forces Medical College, Pune for her MBBS and pursued her MD in otorhinolaryngology at CMC Vellore. She's trained in a variety of surgical procedures such as tonsillectomy, adenoidectomy, septal surgeries, endoscopic sinus surgeries, head and neck surgeries, cochlear implant surgeries, and so on. A recipient of the Moderator Fellowship in 2013, she spent a semester in research training at KU School of Health Professions in Kansas, USA. A keen researcher, she has been the primary investigator of over 10 research projects and has published over 25 papers in peer-reviewed national and international journals. During the COVID crisis in India, Dr. Picardo volunteered to work in the COVID wards to help physicians with patient management. With the epidemic of mucormycosis, she worked with others to formulate a protocol to manage such patients and performed up to 10 surgeries a day. She volunteered at the Christian Medical College Udhavi IMA COVID helpline, which provided COVID-related medical advice, counseling, and logistic supports to people in and around Vellore. Having done so much work in this field, she was a natural choice for being the moderator of this session. A very warm welcome to you, Dr. Naina Picardo, and thank you for taking the time.
Thank you. At the outset, I would like to thank the CEOs of BrainSightAI, Naina, and RimGym for inviting me to moderate this webinar. The COVID-19 pandemic has disrupted the world in ways we have never known before. It has affected healthcare at different levels, and almost all medical specialties have been affected in some way or the other. Although COVID-19 primarily affects the respiratory system, it has been shown to have many neurological and neuropsychiatric manifestations, some of which may be immediate and some may be delayed. It is therefore apt that BrainSight has organized this webinar on the neurological problems with COVID and its diagnostic aspects. BrainSightAI is actively involved in developing solutions for diagnosis and early management of neurological and psychiatric problems. In its short journey of 2 years, the company has been selected as the top 20 companies in neuroscience innovations, and it has partnered with JE Edison and Dassault Systems. So when Naina contacted me regarding her interest to conduct this webinar, I could not think of a better theme than Christian Medical College Vellore. Christian Medical College, or CMC Vellore as it is commonly known, has been at the forefront of this war against COVID. CMC Vellore, as we know, is one of the leading healthcare facilities in the country with strong roots in service and education. In the first and the second waves together, CMC Vellore has treated more than 15,000 inpatients with COVID. In addition, many thousands were managed with home care monitoring, teleconsultations, and telephonic helplines manned by senior doctors. The Department of Neuromedicine and Radiology, like all other departments, have managed innumerable patients with COVID. And today we have two eminent speakers, Dr. Ajith from the Department of Neuromedicine and Dr. Pavithra from the Department of Neuroradiology, to share with us their experiences. First up, we have Dr. Ajith. Dr. Ajith Sivadasan is a professor of neurology with many accolades to his credit. His academic and diagnostic skills are only matched by his dedication to his patients. His special interests are in neuroimmunology and neuromuscular disorders, and he has published extensively in those fields. Over to Dr. Ajith.
Is it fine now?
Yes.
Yeah. Okay. I'll go on to the presentation straight away. So the main focus of this presentation is, as we all know, the COVID infection due to SARS coronavirus, multi-system disease, and neurology, both the central as well as peripheral nervous system, form one of the major organ systems which are affected by this COVID. And of late, we have been seeing a lot of cases right from the first wave on the second wave and the ongoing pandemic as well. So I'll focus on the various general talk on the various neurological manifestations of COVID and I'll just go on to the next phase and leave it to the subsequent speakers to discuss on the relevance of artificial intelligence in fine-tuning management in all these cases. So neurological involvement in coronavirus infection can be subclassified into three main categories. One will be when patients come with absolutely new onset neurological disorders. There could be patients who come in with worsening of pre-existing neurological disorders, or there could be an unmasking of an underlying very incipient, very chronic progressive neurodegenerative illness like Parkinsonism or dementia, which can be unmasked by a new COVID infection. So these could be the broad subclassification of involvement. And whenever we have a new infective agent and a new whatever manifestation, cardiac or neurological, always in epidemiology we studied about whether the infectious agent is actually causative or a pandemic of such a scale, the infection was just coincidental in concordance with the neurological environment. So how will you prove a causation or coincidental? You usually prove whether the association is strong, it is consistent, is the association specific, is there a temporal profile like infection followed by the neurological involvement, or is it due to a invasion of the infective agent into a neurological system, or interplay between the innate and adaptive immune responses? The biological gradient, like what is the severity of infection, the viral load, the antibody titers, is the causation or coincidence biologically plausible and coherent, and is there experimental evidence? But what is one thing is coming out very surely is that the outcomes following neurological illness are directly or indirectly related to the pandemic in majority of the patients who have come across right now. So the basic pathogenesis of neuro-COVID infection, as in other organ system, includes thrombosis, inflammation. Inflammation could be driven by hypoxia, or the viral agent itself can mimic, can provoke an inflammatory response by mechanisms of molecular mimicry. The overall involvement in forms of either encephalopathy or weakness could be related to critical illness of the coronavirus infection, or could be direct neurotropism, or due to, or in other words, invasion of the infection into the central or peripheral nervous system, more likely to the central nervous system, of which there is a lot of data which is coming out right now. So this is regarding the first wave of coronavirus, when we had, just looking at 2 months between August and September, we had nearly 36 patients in the first wave of coronavirus with neurological involvement. The majority, as expected, were arterial strokes. Then we had cerebral venous thrombosis, acute encephalitic syndromes with coma as well as refractory seizures. A few patients with coronavirus myelopathy as well as Guillain-Barré syndrome. Some of the patients were quite severe. We had 2 patients with rhabdomyolysis, that is muscle necrosis leading on to renal, almost leading on to impending renal failure, as well as major malignant strokes requiring decompressive craniectomy. So regarding arterial strokes and coronavirus infection, in our cohort, we actually found that majority were young, or only around 44 years old. 72% of the patient was a young population. Males formed the majority, and most of them manifested stroke usually around 7 days into the coronavirus infection. They had a large vessel occlusion, like the internal carotid artery or the middle cerebral artery. And the coronavirus infection was actually moderate to severe in nearly 86% of these patients. So since then, we have actually started as a multi-center trial of prospective recruitment, and we found a database of all these patients, which are even now coming. Even last month, we had nearly 4 patients with Guillain-Barré syndrome or acute flaccid quadriparesis, which was temporarily related to the coronavirus infection. And as actually the number of cases have been increasing, there has been more and more discussion whether this is just a coincidence, because a lot of people have been affected at the end of the second wave. And as we all know, there's this concept of herd immunity. Almost in some states, nearly 60 to 70% of patients actually having coronavirus antibody in the serosurveillance serosurveys. So whether it is just an incident that the coronavirus is there and the patient has a new manifestation, or it is actually the coronavirus causing a new manifestation, is difficult to prove. But in patients where you had a symptomatic infection and followed by an infection, it looks like association appears to be more explainable than a coincidence. Then with the newer vaccines available, there is this concept of vaccine-induced thrombotic thrombocytopenia, which is also being coming up in a major way, especially from Europe, in which there are patients just like myocardial infarction with strokes as well. This is eminently treatable if you diagnose early. So with this broad introduction, I'll just discuss 2 cases. These 2 cases I thought will be relevant in the discussion what we're going on to have in the next 1 hour or so, in which we'll be looking at how technology and artificial intelligence per se can help in fine-tuning the management of these patients. These two cases are unique in the sense that they are not run-of-the-mill the other cases which we discussed. Both of them require some degree of personalized care, in which we can benefit quite a lot by having machine learning algorithms and deep learning, etc. to look at cases in depth, because they're not run-of-the-mill cases. So I'll just run through these cases for lack of time. So we have actually, this is a 63-year-old gentleman who was admitted with severe COVID infection and hypoxemia within 3 days of onset. He had very high inflammatory markers at presentation. And as early as day 5 of illness, he developed an acute paraplegia with a sensory level at dorsal cord level. And his oxygenation actually improved with dexamethasone and heparin. And over the next 3 days, he went on to have neurological bursting with bulbar dysfunction causing pooling of secretions. So this was a scan actually showing that this is the spinal cord, in which we find that there's a long segment cord involvement, and there is some involvement in the brain also, in the pons and cerebellum and the connection. There's the middle cerebellar peduncle. All these features were suggestive of an inflammatory lesion involving the brain and the spinal cord. This patient's results were amazing, because what we found is that the CSF showed mild cells, very high protein levels. The RT-PCR on the cerebrospinal fluid coronavirus RT-PCR was negative. However, all the inflammatory markers like CSF interleukin 6 level, the CSF antibody levels, as well as the concurrent serum IgG for coronavirus, all were positive. And this patient actually turned out to have what we have like neurological involvement very early into manifestation of the coronavirus infection per se, and demonstrated in specific, like an intense virus specific intrathecal. Intrathecal means within the CSF compartment, within the neurological compartment, an antibody response. And this was corroborated by markedly elevated interleukin levels. So this is very unique, because this patient had a very high antibody response as well as a very relatively low virus load, as demonstrated by the cycle threshold of just 31. The cycle threshold value was very high, which means that the virus load in the nasopharyngeal swab was very less. So this was a hyperinflammatory response, what we call an immune enhancement, because the antibody response occurred within 3 to 7 days. And this is a concept which has been relevant in the, especially in the earlier days when we had the Oxford vaccine and the transverse myelitis scenario and all, whether antibody dependent enhancement or ADE could occur. So some patients who have had a minor subclinical infection or have a cross-reacting antibodies with other non-SARS coronaviruses would have very early and high antibody responses, causing a severe inflammatory manifestation of the infection. So this case, we are actually, it has come through for publication, will be published in the next few months or so. The second case, again, very unique and very rare, was a 37-year-old who was actually admitted elsewhere in July 2020 with a severe COVID infection with acute respiratory distress syndrome, and then came to us nearly 2 months later in September 2020. He was treated for the severe COVID with ARDS with steroids and enoxaparin. His respiration had stabilized. There he developed some bone marrow involvement with pancytopenia, elevated inflammatory markers, and was diagnosed to have a hemophagocytic lymphohistiocytosis. He was treated appropriately for the same and was stable at discharge. And he came to us actually with progressive neurological recruitment. In around 4 weeks' time, he developed lower limb weakness, followed by cranial nerve involvement, followed by paraparesis, then subsequently involving the upper limbs. And at the time of admission, he had severe holocranial headache with multiple episodes of vomiting. So on evaluation, he was found to have involvement of both the brain and spinal cord. Brain mainly in the covering of the brain, that is the meninges, causing craniospinal meningitis picture. And his cerebrospinal fluid showed like 180 cells with normal glucose, very high protein. He had a very unique feature, that is all his macrophages in the CSF actually showed engulfing of the erythrocyte, what we call as hemophagocytosis. And his Epstein-Barr virus in the CSF PCR is also positive. And so the primary diagnosis of this patient is that his clinical syndrome was that of a multiple cranial nerve with arachnoiditis and meningitis. He had a hemophagocytic lymphohistiocytic syndrome, which was treated, and he developed a relapse localizing to the CNS or isolated CNS relapse, which is associated probably with the COVID-19, severe COVID-19 infection, with Epstein-Barr virus also reactivating. Like of late, we have had a lot of cases with varicella zoster causing encephalopathy, skin lesions, etc. So whenever you have a synergistic viral association, a lot of other viruses which are dormant in the body can also get reactivated, and this could be related to immunosuppression as well. So this is again a hyperinflammatory response, and this patient had an initial good response to immunotherapy with intrathecal methotrexate, steroids, and ruxolitinib, and was ambulant, but however succumbed subsequently to a superadded infection. So these two cases basically we have discussed just to show that how complicated some cases could become, not the run-of-the-mill cases, like they could become like have hyperinflammatory responses. So it's very important to have a lot of things in your database while analyzing these cases. So in this context, it's very important to say the role of telemedicine technology, how it has helped us stay connected with our patients, both old as well as new patients, through formal consultations, formally connected, and it has helped in ensure continuation of care. And what has been more and more relevant is that COVID, as we are seeing more and more, is not located to a single domain, like single organ system. There have been COVID myocarditis, ischemic heart disease, just like neurological involvement, your acute respiratory distress syndrome. So it's basically a multi-system involvement, which every physician, every specialist also should know. All the other systems, even kidney has been involved. So what has been coming into practice is the concept of virtual neuro-COVID units, in which all patients in the COVID ward we need to be aware of by the help of something like a virtual rounds can help us stay connected to these patients to systematically study the prevalence of new onset disease and outcomes in these patients. And just I'm concluding with the relevance of artificial intelligence in neurology. What we should understand is that we have come through with all that this is not the first pandemic and may not necessarily be the last. I hope the statement is wrong, but it's very important to realize this. And artificial intelligence is coming up in a very big way. The other domains of artificial intelligence include machine-based learning as well as deep learning of neural networks. All this is going to come up in a good way. And with the use of rational use of artificial intelligence, you'll be able to probably triage patients more efficiently, have systems for home-based monitoring as well as continuation of care. And this can influence morbidity and mortality and also significantly impact the cost. And right now what we are seeing is that there is a lot of cases of significant stress on human resources, which can be probably mitigated to a large extent by rational use of artificial intelligence. And it's just a matter of time before we are going to have medical robots, medical ambulances, etc. coming. We'll be having a subsequent talk on how neuroimaging especially will benefit immensely from the use of artificial intelligence. And this is not applicable to COVID alone. Like we know, like based on AI-based platforms, how CT-based scorings and all can be done at a faster rate for the thorax and lungs, etc. This can be applicable even in a non-COVID context, like disorders like dementia, like based on the neural networks, functional connectivity, etc. You can identify which subtype of dementia the patients have, as well as in epilepsy, like drug refractory epilepsy, in which the scan looks normal. By having quantitative values, and you'll be able to find out any substrate, like this could be a surgically remediable epilepsy. So these concepts are going to spill over to the non-COVID diseases as well. With this, I conclude my talk. I'll be open for questions. Thank you.
The questions are rolling in. There is a question regarding the case study of the 63-year-old patient that Dr. Ajith talked about. The question is this: did this patient have any history of mild cognitive impairment or neurodegeneration? And following from that, basically, does the medical history predispose a person to an infection that later flares into a neurological response?
No, he was a gentleman with diabetes. Otherwise, he was pre-morbidly well. He didn't have it. Meaning he's a diabetic, but was pre-morbidly well prior to the 3 days of onset of the coronavirus infection. That he was probably because of chronic diabetes, he was slightly immunocompromised, with which he went on to develop this. Like in my first slide, I actually put across like the subclassification in which we have actually found a few patients who come in with meaning what you call severe cognitive impairments reported after COVID infection. But when we actually go through the history, like they might be having very mild disconnection problems right from beginning, like which may have been underreported by the family members. So I think in those kind of cases, all your functional connectivity networks, etc., could be of great help in characterizing it. I think it's going to come up.
Thank you, Dr. Ajith. There is another question following up from that, which is a more futuristic one. Since COVID is known to induce changes in the brain, this could be implicated at the neuronal level as increased oxidative stress or protein aggregation. Do you, Dr. Ajith, think such a scenario could predispose the person to develop a neurodegenerative phenotype in the future?
I think it's a far-fetched theory right now, but what is known from some of the autopsy studies is that, like in patients with, again, this goes back to the basics of pathogenesis of coronavirus and neurological involvement. And based on a lot of these autopsy series which I've come across, they have been able to demonstrate in some cases, as we all know, one of the commonest symptoms report this is anosmia or loss of smell. So like that could be due to a local invasion, not just a nasal involvement. There could be involvement of the olfactory bulb and the central nasal pathways as well, olfactory pathways as well. And similarly, there have been demonstration of a lot of thrombi, microthrombi in the brain. Very less demonstration of virus per se, but neurotropism as well as a hyperinflammatory response, like just what happens in the lungs and thrombosis, has been demonstrated. I'm not particularly sure whether amyloidosis or anything, but amyloidosis is just a secondary phenomenon which can occur. I think this is right now where we are probably looking at more like a infective manifestation. But as we have seen, like this could, like you could have a patient with very mild Alzheimer's disease who decompensates rapidly following a severe COVID infection, because all the things like, especially they're requiring oxygenation, there could be hypoxia, which causes a systemic inflammatory response, which involves the brain as well. It could put them down quite a lot, from which recovery again will be protracted. So I think on evaluating, that's one good thing about having quantitative measurements in the brain, like either functional neuroimaging or your tractography, looking at tracks per se, which our AI-based platforms will help us immensely in to prove, meaning to answer these questions more objectively.
Thank you, Dr. Ajith.
As simple as possible, I thought we should highlight the two cases because, meaning it's just not the run-of-the-mill story. It's always like you have some things where you need some personalized treatment algorithms as well as customized care. I think that's relevant in the context where we're going towards technology helping. So these rare cases, whenever they are in databases, which will come into the differentials as well. So that's why I thought we should include the rare cases as well, not the common.
Thank you, Dr. Ajith.
Thank you, Dr. Ajith. That was indeed a very... I'm sure the audience mind has opened up to the diverse manifestations of COVID. Next up, we have Dr. Pavithra Mannam. She is Associate Professor of Radiology with special interest in neuroradiology. She completed her Junior Training Fellowship in Advanced Neuroimaging in Salpêtrière University Hospital in Paris, and is well experienced in special imaging studies such as functional MRI and diffusion tensor imaging. Over to Dr. Pavithra.
I'd like to start by thanking BrainSightAI and Dassault Systems for giving me this opportunity to talk about the novel coronavirus and the brain. Without further ado, we'll go into the slides. The first ever reported manifestations of neurological manifestations of COVID were first reported in 2020 in a group of patients on a retrospective study in Wuhan, China. So in this series, the authors presented about 78 of 214 patients who had neurological manifestations, and the neurological manifestations were mainly in the classes of CNS manifestations, peripheral nervous system manifestations, and skeletal muscular manifestations. So this was a picture taken from their article, which shows the left capsuloganglionic and insular infarct, and to the left is the HRCT of the same patient. So this was probably one of the first cases in the world where they found neurological manifestations during a acute phase illness of COVID-19. Then we had a single case report of meningitis or meningoencephalitis that was associated with SARS-CoV-19, which was again from China. And this was seen in the end of February. This patient, who was a 24-year-old man with no comorbidities, he had fever on day 1, and by day 9, he was found unconscious with a GCS of 6, and he had seizures. His labs showed a WBC count which was elevated. Initial CT brain was normal. CT chest showed ground glass opacity in the right upper lobe and both lower lobes. CSF was negative for other viral etiologies, but was PCR positive for COVID-19 SARS virus. So they subsequently did an MRI and found this area of diffusion restriction in the right hippocampus, and the same area shows swelling and hyperintensity on the flare, and this is a T2 axial showing the paranasal sinuses which are also inflamed. So this was the first recorded case of PCR positive, SARS PCR positive, COVID-19 PCR positive encephalitis. The next large case series systematic review came out in December 2020, and this showed that there were a lot of patients who were presenting with neurological manifestations. The dominant of these neurological manifestations was either an ischemic stroke, a hemorrhagic stroke, or an CNS inflammatory disorder. So this is a pie chart showing what they found in the systematic review. The majority of the cases, the bulk of the pie is formed of vascular strokes, hemorrhagic strokes, encephalitis, and inflammatory disorders, with a few other CNS involvement conditions causing a very small fraction of these cases. So coming to the neurological manifestations of COVID, you can see them in either acute illness or as part of a post-infectious inflammatory syndrome. Now, in the time of acute illness, the lesions can take the form of either vascular or ischemic strokes or hemorrhagic strokes predominantly. This next one is taken from literature, and it shows that there is a occlusion of the left cervical segment of the left internal carotid artery, and that is a CT angiogram scan showing the large hypodense area in the left side of the cerebral hemisphere, and remarkable paucity of vascular branches of the MCA and the ACA. This is the angiogram image showing the filling defect in the left MCA. And there we have a collection of cases with infarct, this showing the left dense MCA sign, this showing an acute infarct in the right MCA territory, an acute infarct in the left cerebellar hemisphere, and an acute infarct in the corpus callosum. So then we have the next bunch of disorders which are all hemorrhagic manifestations, hemorrhagic strokes in the lentiform nucleus with diffusion restriction. Then we have cerebral venous sinus thrombosis with gyral hyperintensities and diffusion restriction. You can see that there is a filling defect in the superior sagittal sinus, and that is the SWI scan showing multiple areas of blooming on SWI. This is one of our own cases, again showing that there is a filling defect in the superior sagittal sinus with cortical vein thrombosis that you can see as a T1 hyperintense signal on the T1 scans, and a large area of hemorrhagic venous infarction. The other thing is a pure hemorrhagic lesion, the hematoma. You can see that the hematoma is in a fairly unusual location. It is in the temporal lobe here, and there is another lesion in the parietal region. So these are the manifestations that you see in the acute phase of COVID illness, which can affect the brain. Then we have the other smaller hemorrhagic lesions, which are hemorrhagic transformation of internal watershed infarcts. You can see a cluster of blooming in the splenium of the corpus callosum and clusters of blooming in the internal watershed regions of the cerebral hemispheres. And then we have this much more diffuse pattern of lobar microhemorrhages, and these we have experience having seen them in patients who are prolonged COVID uh, patients who spend a lot of time in ICU. And I believe this can also be seen when extracorporeal membrane oxygenation is instituted in some patients. So we have looked at the neurological syndromes that can happen in acute illness. Next, we will go to the neurological manifestations that are seen as part of the post-infectious inflammatory syndromes. So now, post-infectious inflammatory syndromes are broadly now known as multisystem inflammatory syndromes, can be seen in children and adults. And it is a hyperinflammatory systemic syndrome which follows an infection with COVID-19 or contact with COVID-19. It's usually seen about 2 to 3 weeks following the infection or following contact with infected individuals. They present with fever, abdominal pain, rash, conjunctivitis, elevated acute phase reactants like ESRCRP and procalcitonin. Now, briefly looking at the pathophysiology of the CNS inflammatory syndromes, they can broadly be divided into neuroinflammatory, where there is an exaggerated cytokine storm which causes damage to the brain, and a post-infectious immune dysregulation which causes damage to the brain. Secondary injury is when there is systemic insult causing an arrest or a hypoxic injury, which leads to hypoxic damage to the brain. Neuroinvasive and neurotropic is no more considered to be part of the post-inflammatory syndrome response. So neuroinflammatory cytokine response and the post-infectious autoimmune dysregulation, which causes an ADAM or an ANIC type of picture. Now, secondary injury is not something that we are going to concentrate on. What are the presenting symptoms in CNS involvement of post-inflammatory neurological symptoms? Is similar to any other acute neurological syndrome and consists of headache, seizures, persistent drowsiness, altered sensorium, and confusion. They mostly occur as an ADAM form, a peripheral spinal cord cauda equina affectation called GBS, or an acute necrotizing encephalopathy, which is also called ANEC. And then, of course, we have two new entries into this, which are press and reversible splenial lesions, which we see very often in radiological practice, and they are not really new to us. But we have been seeing a lot of these as part of this inflammatory syndrome response post-COVID. So again, cytokine storm is the main culprit, and it causes a breakdown of the blood-brain barrier and results in a press or a reversible splenial lesion, which is RSLES. So here we have a patient who presented post-COVID with seizures, and you can see that there is a diffusion restricted lesion in the splenium of the corpus callosum. So they are by no imagination rare lesions. We see multiple reports of this in literature. Next, we have autoimmune immune dysregulation causing ADAM or ANIC. Basically, viral infection and molecular mimicry by the antigens of the virus cause activation of the myelin reactive T cells and provokes a CNS inflammatory reaction. This is a picture from literature showing multiple subcortical and white matter lesions in the hemispheres bilaterally with patchy, hazy enhancement on the post-contrast scans. This is a case of ADAM. Again, another case of ADAM with some cortical lesions as well and brainstem basal ganglia lesions. The next case is a patient who had GBS following COVID. So here you can see that there is thickening and enhancement of the cauda equina nerve roots. This patient is usually present with an acute LMN weakness. ANEC again is caused by a cytokine storm and it results in necrotizing thalamic lesions. Again, ANEC is not new to us. We have seen ANEC in the past, but we are starting to see ANEC in the context of post-COVID illness, neurological illnesses on a fairly regular basis. Again, not unheard of, and you can see reports of them in literature. I'd like to show you a case that we had, a 13-year-old girl who presented with COVID in April. And in late April, she developed maculopapular rash, fever, and lymphadenopathy, along with drowsiness and seizures. This is her MRI scan. MRI scan shows multiple areas of hyperintensity in the brainstem, cortical and subcortical regions of the cerebral hemispheres in a very asymmetric fashion. You can see as you go up that there is a lot of involvement of the frontal parietal, even the corpus callosum, and that is the diffusion weighted scans showing that some of these areas of involvement also demonstrate diffusion restriction. And these were the differentials that we considered in that age group, in that early on when our knowledge of inflammatory syndromes was poor. But now we know in retrospect that she fulfilled all the criteria for MIS-C, and she was finally diagnosed to be MIS-C. This is another patient, again, similar areas of involvement, but a much more florid patient. You can see that, again, a lot of asymmetric long TR hyperintensities in the cortex and white matter of the supratentorial as well as infratentorial brain parenchyma. You can see a fair large number of areas of involvement in the cerebellar hemispheres as well. So this patient also had a reversible splenial lesion in the posterior corpus callosum and splenium, and you can also see other areas of diffusion restriction in the cortical subcortical white matter. So what is the take-home message? Infarcts and hemorrhagic lesions secondary to CVT pure hematomas are usually seen in the acute phase of COVID infections. Post-COVID patterns of neurological involvement are similar to those seen in other para-infectious neurological syndromes. When you see a press-like pattern or an ADEM or an ANEC or a GPS transverse myelitis in the coming months, please be aware of this entity called multi-inflammatory systemic syndromes. Thank you.
The next set of questions is for Dr. Pavithra Mannam. The first question is, you had mentioned in your slides that the hippocampus is effective. And the questioner wants to know if you've come across any studies that have used neuropsych tools to assess the working memory.
Regarding the hippocampal involvement, I believe that they may only have been a few cases so far. And right now, the healthcare system is still trying to manage the acute forms of the disease and, keep morale among patients, public, and as well as the healthcare workers high. I don't believe that there are any large studies that have been done, but we can always prospectively design a study to look at memory in patients who have been affected by COVID. The other thing that we could do is also do functional MRI studies, but in the acute phase when they're sick, it's not very possible to do these scans. So we'll have to wait for them to recover and then have to call them back for the scan after writing up a good proposal, of course, for IRB. So we can expect to see some papers in the future.
Thank you. Another question for Dr. Pavithra. Is there a direct one-to-one correlation that you've seen with the neurological manifestations and that of the viral load?
I'll try to answer that question in two parts. So when it comes to the inflammatory syndromes, that is the neurological multisystem inflammatory syndromes, they usually seen very often in children. And their initial COVID illness is a very mild illness. So going by that, I would say that maybe the viral load was not that high. But the children's immune system is hyperreactive and it is reacting in a very aggressive manner to the existing viral antigens. It is more of a viral, it's a body's reaction rather than the virus itself that causes these inflammatory syndromes. As far as the prothrombotic nature of the illness and causing infarcts in the acute phase, I am not entirely sure if there is a correlation between viral load mm, and the incidence of neurological manifestations. But it is definitely something that is worth looking into. I'm not aware if somebody has already looked into it. If there is somebody in the audience who has experience, can share maybe now.
The third question is again to Dr. Pavithra, a more general question here. As a neuroradiologist, what has been your experience in the COVID times?
As a neuroradiologist, my experience has been that there was a drastic difference in the number of neurological manifestations that we saw in the first wave versus the second wave. And I think we were mentally more prepared for the second wave than we were for the first wave, mentally prepared. So the reality was that we were overwhelmed by the second wave. So I think a lot of patients were managed without imaging them, even when they had symptoms, because of the problems with keeping the room empty for some time, fumigation, whether it works or not. All these kind of concerns may have limited the imaging in patients who may have required imaging. So I have seen, definitely have seen infarcts, definitely have seen CVT. We seem to see a lot of CVT, and definitely infarcts. I have seen microhemorrhages, but these are all anecdotal. The infarcts and CVT seem to form the larger proportion of the cases that we've seen. Now, coming to the inflammatory syndromes, we have seen press pattern in the inflammatory syndromes. I am yet to come across an ADEM or an ANIC in correlation with, in relation to inflammatory syndromes, but I think it's only a matter of time, and we probably will be seeing those if there is a third wave.
Thank you, Dr.
Thank you, Dr. Pavithra, for your presentation. I'm sure all participants would have found it very informative and stimulating. Next, I would like to introduce Dr. Ranganayaki Sathyanarayanan. She is the Neuroscience Research Lead at BrainSight. She has a PhD in Neurochemistry in her bag, and her passion in research has resulted in publications in reputed journals such as Nature. She's a recipient of many awards and grants, such as from ICMR, CSIR, and German Neuroscience Society. Today, she will be talking about how the technology developed by BrainSight has been revolutionizing the field of medical imaging and using it to understand the human brain better. She will also be highlighting the potential of artificial intelligence and machine learning in helping doctors focus, get the answers which they are looking for, and thereby help their patients better. Over to Dr. Ranganayaki.
Thank you, Dr. Naina, for those wonderful words and the kind introduction. I am Dr. Ranganayaki from BrainSightAI, and my topic for today is COVID and the Connectome. As you all know, the aim of this neurogram is to essentially emphasize on the neurological manifestations following COVID-19 infection. The previous two speakers, Dr. Ajith and Dr. Pavithra, have very beautifully brought this out using case study depictions, etc. I will be going one step further, and I will be talking about the changes that happen at the neuronal level, how these neurons talk to each other, and essentially the changes that occur at the connectome following a COVID-19 infection. The world as we know it has changed completely following the worldwide epidemic in 2019 by the SARS-CoV virus. Masks and sanitizers have become our best friends. Social gatherings, meeting people, etc., has been limited to a virtual mode. Work from home has become the new normal. Amidst all these sudden changes, mental health has taken a serious hit in order to cope up with these drastic changes associated with managing the COVID-19 infection. Uncertainty due to the lockdown, uncertainty in terms of employment, isolation, social distancing, etc., have significantly impacted the mental health of across the world. Depression, anxiety, suicidal tendencies have been on a rise during this pandemic phase. All these things are essentially the secondary effects of the COVID, the indirect effects, if I might say, of the COVID-19 infection. However, there are also direct effects due to this virus. The virus has been known to attack the brain cells and the CNS by various routes. This could happen mostly by two ways. One, it could be from the lungs, from the site of infection, and it can be the viral particles can be transported to the central nervous system via anterograde transport through the vagus nerve, or another mode of transport to the CNS would be from the site of infection at the olfactory epithelium, wherein the viral particles are transported to the CNS via the olfactory nerve. The primary protein responsible for the invasion of the virus is the ACE2 protein. ACE2 protein is present in several cells and tissues, and studies have shown increased circulating mRNA levels of ACE2 in the CSF and brain of COVID-19 infected patients. However, this does not directly translate to the protein levels of ACE2. This figure here is a formalin-fixed paraffin-embedded brain section, a postmortem brain section of a patient infected with COVID-19, and you can see that it has been stained for the spike protein, and significant signal has been seen in the cortical neurons, as depicted by the black arrows here. Apart from it's not only the neurons and the cell bodies that house the spike protein, but also the microvasculature structure that surrounds these neurons have also shown increased spike protein in this brain tissue. Apart from this, to establish the importance of ACE2 protein in viral infection has been studied in organoid neuronal cultures. These cultures have been treated with ACE2 inhibitors and have been stained with the SARS-CoV spike protein. And as you can see here, that when in case of the anti-ACE2 treated organoid culture, you see significantly less number of spike proteins present here in compared to the controls, wherein these are isotype treated. As an extension of this, the treatment of organoid cultures with ACE2 antibodies have also shown significant reduction in spike protein signal, as depicted here, wherein these cultures have been treated with the COVID-infected patient CSF in comparison with the CSF obtained from the healthy patient. The reds depict the spike protein. Therefore, having established the viral infection at the cellular level, next we will move on to look at the changes associated at the connectomic level, as in the changes that are associated, as in the changes that happen when neurons talk to each other. There have been several longitudinal and cross-sectional studies that have looked into the long-term effects of COVID-19 infection in non-hospitalized individuals. One such study with a cohort of 89 patients who have recovered from COVID showed that 40% of them complained of headache, 33% showed memory difficulties, 29% of the people showed impaired cognitive functioning, and almost 40% of them had some or the other form of language impairment. In this study, this cohort was chosen to carry out neuropsychological evaluation, resting state functional connectivity analysis, and DTA analysis to objectively evaluate the changes that happen within the brain connectome. With the neuropsychological assessment, the predominant finding was that many of the patients showed very low score when it came to the tests associated with verbal fluency and trail making tests, both of which are an indication of dysfunctional brain flexibility. Apart from that, DTI findings showed significant increase in fractional anisotropic levels in regions like in the white matter, including the corticospinal tract, the inferior longitudinal fasciculi, etc. One of the major drawbacks of this study is that it's not a longitudinal study, but has been carried out in patients who have recovered from COVID-19 infection. There has been another study which is a longitudinal study that has looked into the DTI changes at different time points. And this study concluded that at the initial stages of the infection, the fractional anisotropy values decrease, indicative of degeneration of white matter, following which this fractional anisotropy values gradually increase in specific regions. This could essentially mean a coping up mechanism by the brain, and it could also be an indirect indication of neuroplasticity. However, further studies are required to conclusively prove the same. The resting state functional connectivity analysis was also done in this cohort of patients, and 70 ROIs were chosen. And this here represents the hyperconnectivity in the axial and in the sagittal and the axial plane. This figure here again demonstrates the changes in the resting state functional connectivity of these COVID-19 infected patients in comparison with healthy controls. And this is a graphical representation of the networks that have shown significant hyperconnectivity in comparison with that of controls. As you can see here, networks like the salience network, the ventral DMN, etc., have shown significant hyperconnectivity. The most drastic change was seen in the network associated with the visuospatial function. Auditory network did not show any significant changes in comparison with healthy controls. All these data go to prove one thing, that apart from the systemic effects, COVID-19 infection does not spare the brain at all. Disrupted hyperconnectivity and loss of resting state specificity are few of the characteristic changes associated with the COVID-19 infection. The connectomic changes correlated with associated neuropsychiatric symptoms to some extent. However, we are still not sure if these changes are transient or permanent. If these changes are transient, is there any way or any intervention that could help in reversal of this process? Essentially, all these things points to one thing. We have to understand the brain connectome well to be able to answer these questions. And that's where BrainSightAI comes in. BrainSightAI is developing a software tool known as the voxel box, which integrates multimodal imaging. That is, it takes the data from the structural MRI, the functional MRI, and DTI, and uses artificial intelligence to enable one get quicker, deeper, and richer insights into the brain functions. Using this, we could analyze and model disorders and simulate therapies that could be very disorder specific. Apart from the obvious functions of resting state fMRI, acting as a replacement to task-based fMRI, resting state fMRI can also be used to capture several cognitive networks, including the default mode network and the salience network, and other emotional networks that require extremely complicated task settings. We are also able to provide the functional connectivity analysis across different disorders and show what it looks like in each disorder. Here is an example of schizophrenia versus bipolar. Apart from this, we also show functional activity analysis that shows the differential activation across brain regions in different disorders. Further, we are able to use the regions predicted by our algorithm and use 3D simulation models to increase the success rate of non-invasive brain simulation techniques, including TDCS, TMS, etc. Essentially, our tool, that is Voxel Box, can be used by a plethora of clinicians, including psychiatrists, neurosurgeons, and neurologists. And we are also working towards making Voxel Box a disease-agnostic platform. Therefore, in BrainSight, we are bringing artificial intelligence to neuroscience to enable greater precision in neurological and psychiatric investigation for faster and better patient outcomes. The world needs better mental health, and we believe that BrainSightAI can help enable that. If you also think the same, please feel free to get in touch with us. And here are our contact details. Thank you very much for the opportunity.
Thank you, Dr. Ranganayaki, for that succinct presentation. You have really opened our minds to the possibilities of what technology can offer us.
The last question is for Dr. Naina. You had talked about the impact of COVID on the health system, and the questioner wants you to go into a lot more detail of what that meant. What was the impact of COVID on the health system?
Though your question is very simple, the answer is not very small. If you give me 2 minutes, I just kind of like to share this experience in terms of all the stakeholders involved. That means it has, if you have to use the one word to explain this, you would say that the effect of COVID on healthcare has been immense, and especially in a country like India. And the stakeholders who I talk about are the patients, the healthcare logistic teams, and the doctors per se. So if you look at from the patient's point of perspective, it's been a very difficult period for them, because all of a sudden, when the pandemic started and the lockdown started, suddenly medical care was either inaccessible or unavailable to them. So because of restrictions in travel, they could not go and see their doctors, or their doctors and the hospitals, many of them were shut. So this had significant impact, especially on people who are having chronic diseases such as diabetes and asthma and all. So many of them were like, they need constant monitoring, especially even neurologic patients like those who have stroke and all this. So they could not obtain the kind of care which they needed, and definitely they suffered. And if at all they did fall sick, the other aspect which I want to talk about was the isolation. Whether it was at home in quarantine or whether it was in the hospital, they were all alone, because such was the situation that they could not have relatives with them, they could not have their loved ones with them. So it was mainly managing all these alone. So definitely it caused a period of isolation and even depression in those patients. Second, if you kind of look at from the healthcare system, it was overwhelming, because suddenly there was this rush of patients who needed, so many patients who needed so many ICU beds. And yes, sure enough, our system could not cope with it, because we are not tuned to that. If you look at any hospital system, the number of ICU beds are always less than the other kind of beds. But then when this pandemic suddenly came, that was not what was the need. The need was for a much higher number of ICU beds. And I must say CMC really rose up to that occasion, because it's a very large hospital with 2,000, close to 2,600, 2,800 beds. And it converted so many of its bed into semi-ICU and ICU level. It procured additional and equipments, and opened up 2 more new centers to rise up to this challenge. The other logistics which we had to take care of was the medical staff. So although like I said, it has affected all medical specialities, but at that pandemic time, we needed people to take care of COVID patients. And so all your resources and everything had to be channeled in that direction, whether it was material resources such as oxygen or masks or PPIs, as well as human resources. So like the doctors, for example, I'm a surgeon, and all elective surgeries were stopped, and we were all trained, and we had to undergo training modules to take care of COVID patients. So that sort of a reorganization of the the hospital staff took place. And lastly, if I have to look from the doctor's perspective, it was not easy at all. It was a lot of factors. It was, number one, I would say, yes, like I just said, it was about relearning. So you had to forget what you have been trained on, and you have to relearn skills which are actually needed for the patient. So that was one aspect. The other was thinking out of the box. For example, when the COVID pandemic started and we had to do nasal swabs, we were all sitting, I remember sitting with the carpenter and the fellow to design a booth which would be safe for the patient and safe for the person performing the test, so that you could get very good samples. And yet yet not cause any further spread of COVID. So the other aspect I remember was, managing patients who are all alone. So that was very difficult part, because patients had nobody except you. They just had a phone. With some patients could contact their relatives on phone and all that. So you were their window to the world. And that was an additional responsibility for all of us, because in addition to managing the patient, you were also talking to the relatives and trying to act as the, the in-between person, communicating and seeing that, both patients, both sides are not getting very anxious and all that. I guess the difficulty was when we were with the ICU patients, and you had to make such big decisions, and everything was only on the media, like you were talking on the phone, or you were talking on FaceApp, or you were talking on WhatsApp, and those sort of media to communicate with the relatives. And they were sitting so far away, and they had to make difficult decisions for their parents. It was not an easy period, but by the grace of God, everything has gone well. And like I said, we are still not out of the woods. Well, I hope, things, that's where all this technology will be very useful. And it's very encouraging that BrainSight has come up with so many new ways. And I think that is the way forward, especially in situations like this. Thank you.
We now need to wrap up our sessions, and hence we'll be taking all the other questions offline. For those of you who have left comments in the email box with your email ID, we will be getting back to you. Moreover, if you have any further queries or are interested in the VoxelBox platform or the 3D Experience Lab, you can visit the websites pasted in the chat box. My colleague has also pasted an email ID in the chat box below for any further questions. Let me end this conference by saying a thanks to all of you who have joined us today. It has been a pleasure hosting you. And thank you for giving us your time on Saturdays. A special thank you to our guests, Suhas Pritipal, Dr. Naina Picardo, Dr. Ajith Sivadasan, and Dr. Pavithra Mannam. We appreciate you taking the time to talk about this extremely important topic. Thank you, and we look forward to seeing you all at the next Neurogram.